All right, I think we should start with introductions. My name's Sarah Freeman. I'm a pharmacist by training, but I'm the Director of Telehealth Program Development for ANTHC. And my role is to help create new ways of delivering care right to where the patients need it in their home community. We do that through various telemedicine efforts that we'll talk about today. And it is my absolute pleasure to be able to work with Dr. Ferrucci, and she has had such a great impact on doing some research for telemedicine. So I'll go ahead and let you introduce yourself.
Hi, so I'm Liz Ferrucci. I'm a rheumatologist here at the Alaska Native Tribal Health Consortium. I'm in both clinical practice and do some research, and recently had this study funded by AHRQ, that's an R21 looking at telemedicine and rheumatoid arthritis, which I'll tell you about. But first,
a little background.
Forward. Yeah, but first, Sarah will start by telling you about, and we're having a little trouble with advancing our slide, but there we go. Sarah will start with the history and scope of telehealth in general in Alaska. Then I'll move on to talk about our AHRQ-funded research on the outcomes of rheumatoid arthritis with telemedicine, and then talk to you a little bit very briefly about some proposed future research on telemedicine in the broader context of chronic disease here.
So just to start a little bit on the background of telehealth in Alaska, we've been doing telehealth for about 20 years in the Alaska Tribal Health System. For those of you who aren't familiar with the Alaska Tribal Health System, we're actually a voluntary affiliation of 30 different Alaskan tribes and tribal organizations. And our total patient population is about 170,000 Alaskan Native American Indians in Alaska. Each of those regions is actually autonomous and serves their own geographic region. That actually poses a challenge because they're all on their own electronic health records. We do have one shared Cerner record for multiple organizations now. They also have their own workflows, processes. They're independent organizations. Often our processes may not align perfectly, which is a challenge sometimes for telehealth. Alaska Native Medical Center is actually the hub for any of our tertiary care services and specialty services in the state. So we get folks from all over the state. And I'm actually going to go to this slide first because I think it's going to be a little bit more intuitive. The very bottom starburst right here, hopefully you can see my mouse there, is where Anchorage is and where the feeder hospital for 6 other hospitals across the state. There's 180 village clinics and about 30 different hubs for care across our state. And each one of those endpoints there is where telemedicine can be delivered. So we have probably 200 sites across the state where we can deliver care right to patients in their home community. The different types of models of care that we provide include asynchronous care, which is generally consultative type of telemedicine. We call that store and forward. Think of it like encrypted email with very rich pictures and history of a patient. We can take things like ECG results, spirometry results, vital signs, audiometry, tympanometry, images of the ear, or just general images. We generally will send them from a village clinic, so a health aide, to maybe a primary care provider, and then it may go to a specialist here in Anchorage, for example. We do that for outpatient, inpatient, and emergency services. We've been doing that as our backbone for about 20 years. We started with store and forward because we didn't have the connectivity here in Alaska to be able to handle the broadband necessity for live video conferencing. So maybe about 5 years ago, we switched over to a new model of delivering live video conferencing, and we had enough connectivity where it was actually a feasible method of delivering care. So we do quite a bit of live video conferencing as well. Generally, those are outpatient scheduled visits, which are from one clinic of patients in their home community clinic, seeing either a primary care provider or a specialist in a different clinic setting or hospital setting. Most of the lower 48 actually does a lot more right to the patient's home video visits. We call that direct to consumer. We don't do that so much here because the patients don't have connectivity in their home in those very rural, remote areas. It can be very expensive if they do have it. We also do some on-demand consultations. So if a provider needs, say in a hospital, needs assistance from a specialist, we can do that. We're set up to do that. We do quite a bit of care, this is kind of a newer model, care conferencing or care coordination. We have a patient coming up soon who actually was a child who had a burn, and we're connecting with Harborview Medical Center for that care transition to make sure that our surgeon here has the ability to kind of get the lowdown on what's going on with that patient before we transition care over. We also have started doing some of the Project Echo model for telementoring. Happy to go into more detail on what that is if you aren't familiar with it. Oh. So just to give you a little bit of an understanding of the breadth of services that we deliver here from Anchorage, this pretty much lists almost all of our services that we can provide over telemedicine modalities. One thing that we are working on is behavioral health. A lot of our internal communities, or communities do that internally. We don't have necessarily a service line here from ANTHC, but we're starting to develop that so that can be a broader statewide method to manage all kinds of behavioral health issues. So I'm not going to list them all or name them all, but we've got some unusual ones. And just to give us an understanding of the impact here, as I said, we've been doing it for doing telehealth here since I think 2001, so almost 20 years. We've delivered care to over 100,000 patients, which is, if you think of the 170,000, obviously it's sort of a rotating number. That's 61% of all Alaska Natives are touched by telehealth here. That's a pretty big number. Since its inception, we've created over 350,000 cases of telehealth. We have had over 4,000 providers using our system, and our estimated travel cost avoidance is around $100 million. We tend to see lately about $10 to $11 million a year we estimate in travel cost avoidance. That may not be so comparable to other places in the lower 48, but in the Arctic that may be the case when you're talking about folks who aren't on the road system or have very remote areas to travel to. I think these are a little bit obvious, but it's good to always go over what the telehealth benefits are. Obviously, our main issue is making sure our patients have access to care, whether that be primary care, behavioral health, specialty care, in their home community. We found that, and this is part of what Liz's research will show, that providers tend to have a nicer satisfaction. We get that comment a lot from our community health aides who might be very isolated and feel that they would they really enjoy having additional education from their primary care providers when they're on a video call, for example, with them. Also, improved coordination of transition from hospital to home, or even from specialty clinic settings back to their home community. Obviously, we talked a little bit about minimizing travel. Patient may have to travel for 3 days for a 15-minute follow-up visit, and we're trying to eliminate that. And that saves cost, not only in travel cost avoidance, but also cost to patients who may have to leave work if it's a child with an escort. That can be quite expensive. We find that for pediatric patients especially, and also for palliative care patients, we have more family involvement appointment with the patient, patient's care. We can actually bring people in from even outside of Alaska if we need to have some care conferencing with the family. Often when you're traveling to a pediatric appointment, only one guardian or parent can attend with the patient, and if we do a visit to her home community, multiple family members can be involved in that patient's care. And then we touched a little bit on mentoring and teaching as well. So with that, I'll hand it over to Liz.
Oops. So I'll tell you a little bit about our funded project using telemedicine to treat rheumatoid arthritis. This photo is actually from a trip to Metlakatla in Southeast Alaska, which is how we got there on a small plane. So it sort of illustrates why this is useful to us. So rheumatoid arthritis is an autoimmune disease that can lead to long-term disability as well as higher rates of mortality if untreated. It has a high prevalence in American Indian and Alaska Native populations. And this is a disease where actually there's a lot of data to support the fact that frequent visits to a rheumatologist do improve long-term outcomes. Treatment of this disease with disease-modifying anti-rheumatic drugs, or DMARDs as we call them, makes a big difference. And typically primary care providers are not as familiar with those or comfortable with monitoring this disease. So it's a disease where we think access to rheumatologists is important. As Sarah mentioned, in the Alaska Tribal Health System, the specialists are based in Anchorage at the Alaska Native Medical Center, and that's true for the rheumatologists as well. Rheumatologists do conduct field clinics, typically twice a year in the larger hub hospitals or clinics in the larger communities, and that would be up to about 12 communities, but obviously nowhere near the 200 that we're talking about across the state, and not enough. Not all the patients that are needed to be seen can get in then, and sometimes just twice a year is not enough to be seen. We started using telerheumatology with the video telemedicine or synchronous video visits in about 2015. Just to show another reason why rheumatoid arthritis was the disease we selected, this is actually, on the left-hand side is showing the most common diagnoses that we saw in rheumatology in the Alaska Native population. On the right-hand side is a systematic review of studies of telemedicine and rheumatology, of which there were not very many, actually. That was done by a fellow, John McDougall, working with me and a couple of other people. And basically, in both cases, rheumatoid arthritis is the blue bar, and you can see that that was by far the most common diagnosis seen in using telemedicine in rheumatology. A few things about telerheumatology in the Alaska Tribal Health System that are somewhat unique from how it's used in other practices are here. For one, we integrate, I'm calling it VTC, but that's video telemedicine or video teleconsultation, alongside in-person care. So a regular clinic day schedule could include an in-person visit mixed in with some video visits, which is unusual. But we do that mainly for convenience for the patients and the remote clinics. We have multiple remote clinic sites, as you heard, and the presenters at those sites are not trained in rheumatology or in joint exam specific to what we need, as opposed to some other models of telerheumatology where they really have a trained presenter that does a lot of this specific to their specialty. We do have an emphasis on continuity with the usual rheumatologist seeing the patient and the patient coming to their usual site of primary care, along with some sort of either nurse or health aide in that setting who knows something about their care. The study that we have funded by AHRQ is an R21. The overall goal of the study is to evaluate the impact of telemedicine and rheumatology follow-up on outcomes and quality of care in rheumatoid arthritis. In our setting, it's offered as an option as part of usual care. So this was not a randomized study, but we're evaluating the difference between people who have been seen by telemedicine versus those who have only been seen in person. The aims of the study include, number one, evaluating the impact on disease activity in rheumatoid arthritis, which can be measured and is a standard measure of assessment of how active the disease is at one moment, with the goal being low disease activity or remission according to these measurements. The second aim is evaluating the impact on access to care as well as quality of care for rheumatoid arthritis. And the primary analysis for this study is designed based on the completion of 12-month follow-up, which has not been completed, but I'll show you some of our baseline data. So individuals with a diagnosis of RA seeing a rheumatologist either in person or by telemedicine were invited to participate in the study. As I mentioned, both of these were part of usual care, so they had chosen whether they wanted to be seen by telemedicine to some extent. We had some surveys and medical record review at baseline, which I'll show you on the next slide. We've done telephone follow-up at 6 and 12 months, as well as an additional medical record review at 12 months. And we completed the baseline recruitment in March 2018, so we still have a little while before we'll complete the follow-up. The surveys that we used included the RAPID-3, which is a self-reported rheumatoid arthritis disease activity questionnaire, and that includes disease activity as well as functional status. We also have a telemedicine acceptability and usability survey. From the medical record, we abstracted data on demographics, disease characteristics, and then quality of care measures. And for analysis, we categorized people as being in the telemedicine group if they have had at least one telemedicine visit with a rheumatologist, and in the in-person group otherwise. So the people that have been seen by telemedicine have been seen both by telemedicine and in person, typically. And then we've compared those two groups for all measures. Here are some of the baseline characteristics of the two groups, with the telemedicine group being on the left and the in-person only group on the right. Demographics were pretty much similar with age and sex, as well as disease duration. On average, these people had had rheumatoid arthritis for about 10 years in both groups. The RAPID-3 score, which I mentioned is disease activity, higher is worse. So the telemedicine group did have a somewhat higher RAPID-3 score at baseline. In addition, the telemedicine group had had more rheumatology visits in the past year preceding this. I mentioned that that's one of our outcome measures, but that's more at the 12-month marker. And then I'll show you on the next slide some more details of this, but we had the telemedicine perception survey. We took all the different questions about telemedicine and kind of created one telemedicine perception score, with higher being a more positive view of telemedicine and with it being centered on 0. And the telemedicine group did have a higher, more positive perception of telemedicine, which makes sense since they chose to, or agreed to be seen that way. Comorbidities were no different across groups, and then we had some other measures of disease severity really that didn't differ across groups other than the ones that I've shown you here. These are some of the questions in our telemedicine perception survey. This is a lot to walk through, but basically on each question, the top bar is the in-person only group, the bottom bar is the telemedicine group, the blue side is more positive responses, and the red side is more negative. And what I'll just show you is the ones with the stars next to them are where there was a difference between the two groups. And the biggest one that makes sense is telemedicine is an acceptable way to receive health services was more likely to be answered yes in the telemedicine group. And moving down, just many other things about telemedicine were more positive in the telemedicine group, but some were not. Actually, some didn't have a preference necessarily. I have the baseline RAPID-3 score presented again on this slide for everyone. It's the same data I showed from the last slide, as well as the baseline functional status score, which was higher in the telemedicine group, meaning they had worse functional status at baseline. We do have some data from the 6-month follow-up, looking at the RAPID-3 score at 6 months. It was still higher in the telemedicine group, and the change in RAPID-3 over 6 months was no different between groups, but this is not, we haven't completed all of the data collection to date. The functional status score at 6 months, there was no difference in the mean and no difference in the change over 6 months. But again, this is somewhat underpowered right now, as I'm showing you just preliminary data. So what we found so far is at baseline, the participants who've been seen by telemedicine for rheumatoid arthritis generally are similar to those seen in person, except for somewhat higher disease activity at baseline, more frequent rheumatologist visits in the preceding year, both of which maybe indicate possibly a need to be seen more often. They're not doing as well. They may have been seen more often because of that. As well as the more positive perceptions of telemedicine, which makes sense. Overall, at 6 months, it looks like the outcomes are similar, which, you know, we don't necessarily think the outcomes are expected to be better or worse, although we do hope that people that are seen more often are going to do better. Longer term outcomes aren't yet known, and so really 6 months, we wouldn't have expected a big difference. It's more of a long-term outcome that we're interested in here. We have the follow-up completing in March 2019 for this particular grant, but we hope to continue longer follow-up with a future grant, and I'll mention a little bit about that. And we still haven't conducted the analysis of disease activity, quality of care, or change in perceptions of telemedicine up to 1 year. And this is the grant number that funded that study. And so I'll just say a couple of quick words to round it out about some future research on telemedicine. And this is in the broader context of not just rheumatoid arthritis, but rheumatoid arthritis and some other chronic diseases. Telemedicine is used, as you heard here, in a wide variety of chronic diseases, but also in other places around the world. And there are very few studies on outcomes of telemedicine, especially video telemedicine in the format that we're using it here and discussing it here. It's assumed that it will improve outcomes by increasing access to care, but there's very limited data to support that assumption. There's even fewer studies on costs or cost effectiveness of telemedicine. We've talked about the benefit of lowering travel costs, and we assume that it lowers overall costs, especially in a setting like Alaska, where travel is extremely expensive and burdensome. But there are some thoughts that it might increase some downstream costs by leading to increased healthcare utilization with respect to other tests or other specialties. So studies are definitely needed with respect to that. We submitted an R01 to AHRQ looking at telemedicine in the broader spectrum of chronic diseases. And that was just submitted early July, so we don't know anything about that yet. But I just wanted to share that our specific aims were first to look at the predictors of receiving care by telemedicine video visits for chronic disease within the Alaska Tribal Health System, using administrative data, as well as investigating a little bit more patient preference and provider views using some qualitative data. Then in AIM 2, we will investigate the relationship between telemedicine and clinical outcomes for chronic diseases, using some of those predictors from AIM 1 to use propensity scores for the analysis. And then in AIM 3, we propose a cost comparison of video and in-person visits for chronic disease specialty care. So even if it's not funded this round, we hope to get some similar work funded sometime soon. And just one last word, I have a medical student working with me this summer, Nikki Jordan. She's a just finished first year, starting second year medical student in the Alaska WWAMI program, and through University of Washington, they have a summer research training program. She's been doing a qualitative study where she's done in-depth interviews with providers and patients from any Alaska Tribal Health System specialty clinics, looking at what they view as benefits and barriers of telemedicine, focusing on live video visits. And she's gotten a lot of great information, especially a lot of thoughts from the providers, and is working on analyzing that right now and getting that written up. So that is all we had prepared for you today. We are open to questions if you have any.
Great. Well, thanks, Liz and Sarah. That's a great presentation. I like your graphics too. Maybe I could kick it off with a question. I've seen you give parts of this presentation before, but I realized there's some things I didn't know about how you're kind of carrying out the project. Do the patients who choose the telemedicine option, do you actually see them more often? Do they have more visits with you than the other group?
That's one of our actual outcomes that we're actually planning to analyze that as of the more of the long-term follow-up. But yes, it looked like at least at baseline, the people that were seen by telemedicine had more visits in the preceding year prior to the study start. Yes.
How about during the time frame? Do you anticipate that you will see them more often than you would have if you just do your regular fly out to the hub community and do an outreach that way?
That is the idea, yes, that by having the telemedicine as an option, they would not have to fly in, and so it would be easier to get them seen more often. Mm-hmm. Yeah, but some of that still depends on, there's still only so many rheumatologists around, and so still have to be squeezed into a clinic schedule with the rheumatologist, and that without having additional rheumatologists, it may not be as many more visits as you might think, but yes, that's the idea, is they could be seen more often.
I imagine one outcome is you might see a paradoxical increase in utilization and an increase in costs, actually, if some of your patients are just staying home in their home village and aren't getting seen at all. Is there a way you're accounting for that in the potential cost side of it?
What do you mean by if they're just staying there and not getting, oh, you mean, okay, I see what you're saying. Yeah, that's exactly what I was saying, is that there is a, especially by the payers, there's a concern that actually telemedicine is increasing costs. Right. And in one sense, is it necessary care that was being, that was not being delivered in the past that's going to improve health outcomes? And then is the cost worth, worth it because it's going to improve health outcomes versus is it unnecessary cost in the downstream? Yeah, we're working with a health economist on that third aim. So yes, we will definitely be taking that into account.
Yeah. It's sort of what's been defined as a different pocket problem, where for the ongoing care, they're being paid for out of their regular insurance, but what you're trying to avert are those long-term costs, which are down the roads, and they might be paid for out of a different pocket by someone. So I imagine you're taking a societal perspective on that health economics evaluation rather than by insurance provider or by clinic.
We're actually doing it from a few different perspectives so that we can be able to answer those questions. Yeah, and I think, for rheumatoid arthritis specifically, it's a little bit harder to show a short-term cost benefit, and there probably isn't one. For other diseases where there's a higher rate of hospitalization that could be prevented using telemedicine. So one of the big ones that's used here is for congestive heart failure. And in that case, if you have excellent heart failure management, you can prevent hospitalizations, which would prevent medevac costs, hospitalization costs from the insurance perspective, whereas we're probably much less likely to show it on the diseases that are sort of have less severity or less urgency to some of the complications.
Great. Let's open it up to questions from other folks.
So I'll throw a question out there. I'm curious about, so this is not unique to Alaska. This is done in other parts of the country and so forth. Do you have any comparison studies to know how well, longer term studies, since yours is so new?
With respect to rheumatoid arthritis, that systematic review I showed there were about 12 studies, and they were dating back to a long time ago before the same modality was being used. So the answer is basically no, not now. I think with respect to some other diseases, there are some more studies.
Yeah, I think that I'm not sure how comparable we are to those scenarios. In fact, partly because we employ community health aides, which is a unique provider type for Alaska. And so they're essentially physician extenders. They're licensed, they're certified to deliver healthcare. We don't have a 911 here. They go to the health aide. So for all emergency services as well as their normal care. So a lot of what we're delivering and the modes we're delivering may not be as comparable. And I would also say that most of the U.S., and I'm comparing to the U.S. mostly, deliver a lot of primary care and urgent care over video telemedicine, and a lot less specialty care, unless it's remote patient monitoring where somebody has a device in the home and is sending data regularly, say they've recently been discharged for a heart attack or potentially congestive heart failure. Those are really common things for folks to have at home. Those are very different types of models than we do here. So we haven't really found anything that's super comparable here, and so we're hoping to have some data, at least to start with, that others can compare to us maybe.
Thank you.
Ms. Roberto, I have a, I guess, comment and question. The comment is related to sort of the model in Alaska with the community health aides. That's something that global mental health field actually utilizes in low and middle income countries. So when I was at NIMH, I was a program official for global mental health, and we dealt with severe mental illness and in some cases suicide prevention in low and middle income countries. And that's something that's been really pushed forward, again, because of the lack of sort of specialized trained psychiatrists or other specialists in those sort of rural and remote regions. So I think that might be somewhere down the line a nice comparative sort of a nice sort of pattern to compare between what's being done here in the U.S. and the global mental health community. Which brings me a little bit to my question that we use part of our global mental health strategies of collaborative research hubs to develop American Indian Alaska Native hubs for collaborative research on resilience and suicide prevention. And that brings me to my question, of which, in terms of, you mentioned at the beginning trying to develop approaches of telemedicine for behavioral health, and I'm interested in learning sort of a little bit more details about what kind of elements you're including. How is that beginning to take shape going forward?
Here at ANTHC, I think we're in our very early stages, really strategizing what that would look like and where to start. Some of our partner regions are already using telebehavioral health, mostly with video conferencing, both with groups and also individual patients. And so I would say they are doing the gamut of behavioral health care. So a lot of villages will have a specific telebehavioral health room, if you will, that's in a different location than the medical clinic rooms. So it's not an exam room, it's much more comfortable for the folks to participate. I'm not exactly sure, because I don't have all of their data, what exactly they're doing. I can tell you what we're trying to do. We know that there's a paucity, there just isn't enough behavioral health out there. We have behavioral health aides, and that does help. We're trying to figure out what can we add on that is a need from a statewide perspective. And certainly suicide, substance use disorders are going to be at the top of the list. So we haven't started. We recently just hired some folks, some clinicians who can provide that type of service, and we're just at the formative stage here.
Okay.
We have talked about things like how do we bundle services. It's difficult for patients, even for those emergent needs, those crisis situations, whether it be sexual assault, whether it be a suicide crisis, any other kind of behavioral health crisis. Where do people call, and can we kind of coordinate that for the state so that it's easier for people to just make a connection really quick, so there's not 20 phone numbers they have to call. We're just trying to think of different strategies that might work here, and we haven't quite figured that out yet. We'll get there though.
Thank you.
Liz, you mentioned kind of the expansion of telemedicine and other chronic disease prevention activities, and it reminded me that AHRQ has a kind of a monitoring mechanism or a scoring system for preventable hospitalizations.
Right.
Basically, it looks at several different conditions that would be either preventable if you had good primary care services to catch problems early, like urinary tract infections that didn't evolve into pyelonephritis and require hospitalizations. And the other side of it is for people who have chronic diseases. Rheumatoid arthritis isn't one of them, but it could be. And sort of, if you have good systems of ongoing care, you could prevent relapses and complications. And so we looked at those rates of disease in the Alaska Native system and compared it with non-Native Alaskans for the Healthy Alaskans 2020 project, and found that for chronic obstructive pulmonary disease and congestive heart failure, those are two conditions that within the Alaska Native system, higher rates of hospitalizations that were presumed to be preventable were occurring than in the general population. And we assumed a lot of that was because of remoteness and difficulty in access. And it seems like telemedicine would be a good way of addressing those ongoing problems with checking in with patients, making sure they're taking their meds, et cetera. And I don't know if is that part of what you're going to be looking at, or is that an objective you think would fit well with your grant application that you put in?
So I cited your paper in our grant application.
Oh, good.
Yes. So I'm
It's
very familiar
useful.
with it. Yes. It was very helpful. I think that ended up not being our primary focus, but it was a secondary outcome, partly because we actually don't have very many visits for pulmonology or for the lung diseases. So the only thing we could really focus on would be the cardiac diseases. But we did include that as one of the things we will be proposing to look at.
It brings up one of the challenges that I'm sure you encounter as rheumatologists, is that when you have a video teleconference, there's only some things you can assess. You have a kind of a scale of subjective assessments of patient's function. You can look at a joint, but you can't put your hand on it. You can't say how boggy it is, how red and swollen it is. You might be able to get redness, but not the heat side of it. And same with the limitations of listening to somebody's lungs, or even a cardiac exam can be kind of daunting. How do you deal with those as a provider? Do you try to work around those, or are there certain aspects of your normal exam that you just realize you can't do through telemedicine?
Yeah, so the way that we deal with it, because I mentioned kind of briefly that we do it differently than some other rheumatologists in that I don't have a trained presenter on the other end, but a lot of other rheumatologists will do it only to one site, and they train somebody at that site to get good at the joint exam and to be able to help them with that. So we're limited. That just won't ever work here with the 200 different clinics and turnover and so forth. So what we do, a couple things. Number one, we never use it for initial visit. So we always make the diagnosis in person the first time and document, what joints are swollen and so forth at the initial visit. We only use it for follow-up. And we wouldn't use it for every follow-up. We would sort of intersperse, telemedicine and then in person, depending on, something like every other visit or something like that. So yeah, there is a limitation to the physical exam. And if you're doing something that really requires a physical exam, it doesn't work as well. But a lot of times we will have made the diagnosis of rheumatoid arthritis, started someone on some medication that requires a certain amount of monitoring, and we can get enough from them that they're getting better and they're tolerating the medication and they're getting the labs they need to monitor the medication. And I think that's better than not seeing them at all. But yeah, it's not perfect as far as being able to do an exam.
I see Sarah Yoder has joined us. Hi, Sarah.
Sorry, I'm like right at the very end. My Outlook didn't ding me with a reminder.
Oh, good. Well, we're glad to have you with us. That was a really great presentation, Liz and Sarah. Thanks so much. Really fascinating application. I'm really glad to see you guys are evaluating it. I think there's a lot of things we do in healthcare that don't get evaluated, and so taking the extra effort that you're doing will make a big difference in the long run about proving effectiveness or evaluation. So we appreciate that. We're coming to the end of our time, and I want to be respectful of people's time. And maybe we'd have room for one other question if somebody else wanted to jump in. If not, I'll just mention that we meet on the third Tuesday of the month for our health and well-being collaboration team.